I am going to be talking to you, shifting gears a little bit, and talking to you about the larger topic of financial toxicity and specific issues related to coverage and out-of-pocket spending for fertility preservation. And in full disclosure, I'm actually a GI medical oncologist, so I treat mostly older patients with incurable cancers, and this idea of fertility preservation really doesn't enter the conversation for us much of the time. But I do think a lot about financial toxicity. And what really struck me as I was preparing for this talk is that the cost issues related to fertility really haven't made an entree into the literature about financial toxicity. And I think that's a big gap, and hopefully this will be the start of some more rigorous study into financial considerations and barriers in oncofertility. I have no disclosures. So I'm going to start by just stating some very obvious things to sort of introduce this topic of financial toxicity in cancer. And then the latter half of my talk, I'll talk more specifically about fertility. But this, I think most of you are aware of, that the U.S. spends far more on healthcare in general than almost every other developed country. Our outcomes are not necessarily much better, nor is overall lifespan. And in particular, healthcare costs in the U.S. are rising at a much more rapid rate than in any other developed country, and essentially far outpacing GDP. And if we think about, I love to share this infographic from an IOM report from 2011 that really puts into perspective the idea that if other costs had increased for common consumer goods at the same pace that healthcare has increased over the last 50 to 70 years or so, basic things would be virtually unaffordable. What's more concerning is that cancer drugs and cancer medical treatments are the most rapidly growing area of healthcare spending. And this trend in general is really not sustainable, and we are seeing some consequences of increased healthcare spending on our patients. One example is that we're seeing an increase in cost sharing. So this slide from the Kaiser Family Foundation shows that for employer-based health plans, combined totals of premium and out-of-pocket costs for co-pays, deductibles, and coinsurance have increased by over 50% over the last decade or so. In addition, in oncology, we're seeing, or I guess across health plans in general, we're seeing an increase in multi-tiered prescription formularies, which really disadvantages individuals with cancer who rely on specialty drugs. So in multi-tiered prescription formularies, high-cost specialty drugs are usually associated with a percentage copay. So 20% of, for example, a $10,000 a month drug can add up very quickly. Now, the ACA has put some limits around how much an individual with cancer or a family can spend, or with healthcare can spend over the course of a year. So in 2017, the maximum out-of-pocket spending for an individual is around $7,000, and for a family is around $14,000. But importantly, these out-of-pocket limits don't include premiums, and they don't include uncovered services, which is relevant because fertility preservation is generally uncovered by most health plans in most states. And importantly, I think what's striking is that most people don't really have money to spend when faced with a big health shock. So this is data from the 2010 Survey of Consumer Finances, which shows us that liquid assets, even for people who are 400% or greater than the federal poverty level, still wouldn't pay for the out-of-pocket limit in an ACA plan in 2017. And there was recently a study from the Pew Charitable Trust Fund that indicated that only 37% of Americans would have enough money in the bank to pay $500 to $1,000 for any emergency spending. So people just don't have this kind of money lying around. And naturally, a consequence of this is that we're seeing that healthcare debt is a huge problem for patients in general, and particularly for individuals with cancer. So healthcare debt in general is the largest category of consumer debt and far exceeds debt for utilities, mortgage, and other categories. And healthcare debt can often be buried inside of credit card debt. So a lot of people charge things, medical bills, on credit cards. And so why is this important, what I've just told you? Why should oncology providers care? I mean, shouldn't we just tell people what the treatment options are, what the state of the art is, and not worry about the cost aspects? Isn't it our mission just to provide information and sort of be objective conveyors of scientific and medical advancements? Well, I think this is an issue that oncologists should deeply care about. First, because patients with cancer are at particularly high risk for financial hardship and at higher risk than individuals without cancer with other chronic diseases. Financial concerns are rarely discussed with providers, and many studies have shown that this is true, that communication about costs rarely happens. But we know that cost concerns can impact patients profoundly. It affects treatment decisions and adherence to therapy, quality of life, and recently some data suggests that financial issues might affect survival. And finally, what's relevant, I think, most to this audience is that fertility preservation represents a significant out-of-pocket cost burden, or really an untenable option for many who cannot afford it. And we'll circle back to that later, but I wanted to highlight this idea of financial toxicity. So this term was coined in the last 5 years or so, and really is a term that encompasses a variety of financial experiences that people with cancer face. So it can range from the material aspects, financial aspects, to the more psychological aspects. So things like debt, difficulty meeting household expenses, loss of job and employment, sometimes permanently, debt, bankruptcy, and then this anxiety or worry about how am I going to pay my bills. And many studies have shown that younger cancer patients are at higher risk for financial toxicity. And this is particularly concerning because this is the same population that may be wanting to consider fertility preservation. So I'm just going to show you a few studies that have really tried to quantify and estimate the proportion of people with cancer in general that deal with financial issues. So this is a study from Robin Yabroff at the NCI that used data from the Medical Expenditures Panel Survey to look at the proportion of individuals with cancer that face material financial hardships or psychological financial hardships, so more of the worry or stress about finances. And this is a problem that's faced by at least 20% of individuals with cancer. We did a population-based survey a few years ago of all individuals with colorectal cancer in Western Washington Sea region. And what we found is that 38%, so nearly 40% of patients experienced a major financial hardship. So about 20% of patients reported debt, and the mean debt was in excess of $25,000. Almost half had a decline in their income. And there was a small but not insignificant proportion of people who had non-adherence to their medications as a result of cost concerns. So skipping doses of medicines or refusing treatment to save money. And what we found when we looked at factors associated with financial hardship, out of all of the factors that we looked at, annual income, not surprisingly, is associated with a greater risk of financial hardship. But importantly, as people get younger, the risk of financial hardship goes up. And we don't have too many people in this sample that were that would fall into the AYA category because we looked at colorectal cancer, which is a disease of older patients. But you can imagine the risk would proportionally go up as people get younger and have less savings and are more dependent on employment. Another study which kind of highlights this issue is was a study we did a few years ago looking at rates of bankruptcy filings in individuals with cancer in Washington State versus matched control, so people without cancer. And what we found is that cancer patients were 2.65 times more likely to file for bankruptcy compared with matched controls. And similarly, we found that across all of the most common cancers in which bankruptcy filings were seen, the risk of bankruptcy was far higher in individuals who were younger, so represented by the blue bar, this age 21 to 44 group, and this is true in lung, breast, prostate, colorectal, thyroid cancer, and heme malignancies. I mentioned before that, that we're starting to see evidence that cost concerns affect treatment adherence. There have been a number of studies looking at this. I'll just share one as an example. So this is a study conducted by Stacy Dusetsina from UNC that looked at patients with chronic myeloid leukemia who initiated imatinib, which is a medicine that is essentially mandatory in these patients and improves survival dramatically. So they looked at the average monthly copayment for this medication, which was around $100, and they stratified copayments levels into the highest copayment quartile and the lowest copayment quartile. And compared with those in the lowest copayment quartile, people who paid more for this drug had a greater likelihood of discontinuing the medication and a greater likelihood of non-adherence, supporting the idea that cost affects decisions to continue treatment, to start treatment, and adherence. This is a study that looked at quality of life in people with lung and colorectal cancer based on how much money they have in the bank. So people represented by the blue bar who have less financial reserves, so they basically don't have enough money in the bank to come up with at least 2 months of their household expenses, reported lower quality of life on various scales compared to people who had more financial reserves. So how much money we have and we feel how much financial security we feel that we have affects quality of life. And in the bankruptcy study I mentioned just before, we did a subsequent analysis that looked at in people with cancer who filed for bankruptcy, what is the risk of dying from cancer versus those individuals with cancer who did not file for bankruptcy? And we matched patients who filed versus didn't file for bankruptcy using propensity score matching, controlling for various factors we think might be relevant to mortality. And we found that people who filed for bankruptcy had a significantly greater risk of death than individuals with cancer who did not file. So the financial issues related to cancer are not trivial and may have profound impact on the quality of our patients' lives. And so I think that we've made some progress over the last decade or so. There's been a real recognition that this is an immediate and pressing issue in oncology, starting with the 2009 ASCO Cost of Cancer Care Task Force guidance statement, leading to terming the financial toxicity by one of my colleagues, Dr. Zafar at Duke. And then I was fortunate to be able to participate in the NCI Financial Toxicity PDQ, which is sort of a summary of all of the existing literature on financial toxicity in oncology. But like I mentioned earlier, a glaring omission in this PDQ is that fertility preservation is mentioned nowhere. And so we got to change that. So moving on to costs of fertility preservation. So I pulled these data from, these numbers from the Livestrong Foundation, and here are sort of what their estimates are for common fertility preservation interventions. So egg and embryo harvest and freezing around $10,000 to $13,000 per cycle. Storage fees for eggs and embryos you can see listed here, $300 to $600 annually. I think this is an underestimate based on some conversations I've had with many people since. Ovarian tissue freezing, you can see here, sperm banking, the cost for male fertility preservation less than women, but still not an insignificant cost. And I think that these costs really raise some questions to me as someone who thinks about financial toxicity a lot. First, to what extent does cost affect decision about whether to pursue fertility preservation or not versus other barriers, such as the sort of urgency of starting treatment and so on? And I know there's been some work and even some posters at this meeting that have tried to get at these different barriers, but how much does cost play into that? And I would argue that it would probably be a really significant barrier for many people. And then to what extent would out-of-pocket spending on fertility preservation affect the following? Number one, the ability to afford subsequent cancer care, clinical outcomes, future financial health well after cancer diagnosis and treatment, and then the ability to afford a child. because we know that it's expensive to have a child and raise them, $250,000 by these recent estimates by the Department of Agriculture, which shocked me as a mother of 2 kids. But in any case, I think that it's important to consider this concept that what is the impact of scientific advancements in oncofertility, which are so very impressive as sort of a newcomer to this arena, if patients and families cannot afford these technologies or go bankrupt as a result of these technologies. And ultimately, availability of technology does not equal access. And so we need to do a better job. And so I think there's been a lot of momentum to try and change coverage policies across the country. Many of you in the audience have been involved in this, and I commend you. Just to review, I mentioned that fertility preservation prior to cancer treatment is not universally covered. And you can see here that only 15 states that are highlighted in red actually mandate coverage for infertility treatment in general in health plans in the state. And this applies only generally to women who are less than 40, who are married, who have tried to conceive but were unable to over the course of a year, who are not in a public health plan, and who are otherwise considered healthy. So this is not the kind of patient that we're talking about in this meeting. And so there are 2 notable exceptions to that, and there are 2 states that have recently passed legislation to sort of amend the definition of infertility from what I just mentioned to a scenario where a medically necessary treatment may directly or indirectly cause iatrogenic fertility, in this case, cytotoxic treatment. So in Connecticut, legislation passed in June of 2017, followed shortly after by legislation passed in Rhode Island. And I have to point out that these efforts were really spurred by passionate individuals who spent a lot of their own time trying to lobby for this. And those of you who know Melissa Thompson know that she was heavily involved in the legislation passing in Connecticut. And so it's also called the Melissa's Law for Fertility Preservation. This is Melissa with her 2-year-old Poppy on the right there. And I think what really was important is her personal story, her persistence, and her advocacy. But I think there are still some major gaps despite these successes. So first, there's no mandate for public health plans, including Medicaid, to cover fertility preservation. While the IVF cycle may be covered, storage fees are not generally covered. And importantly, something that I've heard in just some casual conversations now that I've been learning more about this topic is that the logistic burden of handling the cost-sharing bills associated with ovarian stimulation and the uncovered storage fees during treatment can be substantial when people are going through treatment. So I wanted to highlight a couple really interesting fiscal analyses that have tried to make the argument that on a larger scale, it would be not only the right thing to do, but would be fiscally within the realm of other things that are covered by health insurance, and also in the interest of health plans to do. So this is an analysis from the U.S. healthcare perspective, actually conducted by Dr. Woodruff and the group here at Northwestern, published in JNCI just earlier this year, that really tried to do a national cost projection for controlled ovarian stimulation and oocyte retrieval in women aged 15 through 44 with newly diagnosed breast cancer. And the sort of comparison or reference for this cost projection was breast reconstruction surgery, which, based on 2 pieces of legislation, is mandated coverage in both private and public health plans. And so in the case of breast reconstruction surgery, the authors estimated that 102 cases in 2014, there were 102 cases of breast reconstruction surgery in 2014 that resulted in a national cost of $1 billion. So with that as the reference, what is the cost projection for women undergoing ovarian stimulation and oocyte retrieval? So there were some assumptions made in this analysis. First is that there are 29,000 new cases per year in the U.S. of women with breast cancer who fall into the age group where this might be considered, and that of these 19,000 women roughly would be eligible for this procedure based on their anticipated treatment regimen, and that about 50% of these women would desire fertility treatment, and that a single cycle would cost approximately $12,700. Here's the sort of algorithm that got us to that number of basically 9,000 women who might be desirous of fertility preservation. And the authors estimated that if 100% of these women actually underwent fertility preservation one cycle at a $12,700 cost, that the total upper limit of spending, healthcare spending in the U.S. would be $126 million per year. But if a more realistic percentage of women actually went through this procedure, 3 to 10%, which is sort of what the current rate is, that these costs would be $3.8 million to $12.7 million range. And this is versus breast reconstruction costs in 2014, which approach $1 billion. So I thought this was a really interesting analysis to sort of put this into perspective. So it's not really a cost problem relative to what's done and what's covered. It is a huge cost problem for women who are currently paying out of pocket for these procedures. Another fiscal analysis done by Fertile Hope and Livestrong used a similar kind of analysis, but conducted this from the payer perspective. And so what they were trying to do is just try and understand for a payer with all its members, how much would all of the members have to pay if they decided to cover fertility preservation in women who met criteria for it with cancer. And they made also many assumptions. You can see here the average costs. This is not just women, rather, this is both women and men. So anyone who could potentially be eligible for fertility preservation. And so they took into account percentage who were likely to pursue, the average cost of sperm banking and embryo freezing, the number of cycles for sperm banking and embryo freezing, and then what the cost share is for the member, or for the individuals undergoing the treatment. So they assumed here total membership in this theoretical health plan of 1 million members, and they estimated that of those 1 million members, about 458 would be diagnosed with cancer at an age where fertility preservation would be relevant, and that 275 of these individuals would be at risk for infertility, and then 34 and 32 men and women would undergo fertility preservation treatments. And here you can see the total costs, and the total cumulative cost per year would be around $400,000, which translates into around 3 cents more per member per month. So I think when you see an analysis like this, it really puts into the perspective that while each cycle is expensive for an individual, if you distribute these costs with the assumption that this is the right thing to do, it's not going to break the bank. And there are a lot of other areas in healthcare where we spend a lot for no gain whatsoever. And I think ASCO has done a good job of highlighting some of these things, giving chemo to people who have poor performance status, doing tumor marker testing where it's of no benefit, advanced imaging, and so on. So while this discussion on improving coverage for fertility preservation is ongoing, patient assistance programs do play a role. And most of you in the audience are far more familiar with the logistic aspects of this than I am, but there are a number of organizations that provide patient assistance for fertility preservation. The Heartbeat program, which assists with fertility medications, and Livestrong Fertility. There was an abstract in ASCO this past summer that looked at all of the individuals who were referred between 2004 and 2011 to Livestrong Fertility for financial assistance. So this amounted to around 1,100 men and 1,300 women. And they actually quantified the cost savings for what Livestrong Fertility was able to provide to these individuals. And essentially, $375 per man and about 6,500 cost savings per women who were referred for assistance. So assistance programs, I think, can play an important role. In summary, financial toxicity is a serious and growing problem in oncology. Cost of care issues can have negative impacts on care and outcomes. And fertility preservation for young patients with newly diagnosed cancer is not covered by many plans, resulting in higher prohibitive out-of-pocket costs, and we need to do a better job of being transparent about what these costs would be, advocating for coverage changes at the state and national level, and referring patients to organizations that can assist with these out-of-pocket costs. Thank you very much.
That was just a tremendous talk. Thank you so much. And so my question is there an intersection that one could look at for the financial toxicity on the downside? And it does cost to raise a child, but is there a psychosocial upside to that improves that mortality outcome? The thing that got me so amazed by this financial toxicity topic was what you showed in terms of the fact that it's not just poorer health, but shorter lives. That is really part of this, the underpinning of the toxicity. And is there something that can change that curve, even if it seems like the cost of a child is expensive? Is there an upside to that that could be analyzed in a way that you could show that mortality curve changes in some way?
Yeah, I mean,
an intervention arm.
Yeah, I think there's so many sort of even intangible benefits to being able to have that opportunity in life that could translate into financial benefits as well. And I think that what's interesting about fertility preservation is that it happens really before cancer treatment happens. So the timing of this is really tough, because it's really before all of the other treatment bills start rolling in. So I do wonder how it affects downstream care. But if to answer your question, I think you could look over a long time horizon and really quantify the benefits to people.
I had one, maybe this is too complicated for answering in this period of time, but I'm wondering, how do we compare, because what we know from countries, for example, where this is available and there are still low rates of uptake. So, for example, in the United Kingdom, I think the last data that I read was something like 6% of women who were eligible for fertility preservation based on cancer treatment alone, only 6% availed of it. So is that more like psychologically, what do we make of that in terms of this impact in the U.S.?
Well, it's interesting. That's interesting data, and presumably it's a covered service in the UK. So obviously this is not the only barrier to uptake, and so a lot of the barriers that have already been discussed at this meeting would apply. But I do think it's still probably even more, much more relevant barrier here, where it's not covered in most instances.